Did it look all right?
I am here with Lisa Keller, a clinical nurse specialist and certified psychotherapist who has worked in the field of psychiatry for 30-plus years. She is currently employed as a nurse clinician at Milestone Centers Incorporated, a community mental health agency in Allegheny County. Ms. Keller, how common is depression and who suffers from it?
Well, it's been estimated that about 5 to 12% of men and 10 to 25% of women experience depression at some point in their lives. It is the #1 cause of disability in the world. Worldwide, 100 million people suffer from debilitating depression. It occurs across the lifespan, in both genders, across socioeconomic demographic groups, and in all ethnicities. It has long been recognized as a serious problem in the elderly population, particularly those who live alone, but recent studies are showing that depression is on the rise in children and adolescents as well. The numbers are kind of all over the place, but I think it's safe to say that up to 60% of middle and high school students admit to feeling sad and hopeless at times, and as you cited in your research, 20% will admit to thoughts of suicide on at least one occasion.
And what are the causes of depression?
There's no one single cause of depression. It appears to be the combination of many factors, including, first would be genetic vulnerability. There is a clear hereditary link. It's also obvious that it does involve changes in brain chemistry, and that is sort of the medical model of psychiatry, particularly in the levels of neurotransmitters in the brain. It's also related to health. There is definitely a depression component to many chronic health conditions, and it's also related to other mental illnesses. It's not unusual for someone who has an anxiety disorder or schizophrenia to have comorbid depression. Exposure to trauma and grief appear to be triggers for depression, as do life changes, stressful life circumstances, events that are difficult to cope with. Also, a number of medications that people use may have side effects of depression, and the use of substances and or addiction are also related to the disease.
And how is depression diagnosed?
Well, there aren't really any lab tests or diagnostic scans that will reveal or confirm depression. I do recall many years ago in the mid-'80s, there was kind of a panacea that psychiatrists had either discovered or created a lab test that was called the dexamethasone suppression test that they thought would definitively diagnose depression. So for a couple of years, everyone, that was wildly and widely used. And finally it was determined that it wasn't a great aid in diagnosing or treating depression, so it sort of fell by the wayside. Generally, diagnosis occurs as a result of a professional evaluation, and what this evaluation should include is, #1, a medical history, so that other physical conditions that would be contributing can be ruled out, such as thyroid disease. A good family history is important, but primarily diagnosis is going to be based on self-reported symptoms that are described in a face-to-face interview. There are some questionnaires, some surveys, some inventories that can be helpful in helping people describe their symptoms. But basically, what the evaluator is looking to find or to define are changes in a number of patterns. And these patterns are changes in mood, changes in sleep patterns, either more sleep or less sleep than usual, changes in energy, more or less. And when I say more, it usually is some kind of an agitation or restlessness that's described. Changes in appetite, either increase or decrease. Changes in concentration, changes in interest patterns, things that usually interest individuals, they have no interest in doing. And, of course, evaluating for thoughts of self-harm. The responses that are provided will be matched against what the evaluator is observing and seeing with their own eyes, and then compared with the formal criteria that's been established for diagnosis. I'd like to just say a word about the issue of diagnoses. I hate to see anyone, professional or patient, put too much stock or too much emphasis on a diagnosis. It's not intended to be a label. I mean, so when we talk about diagnosis, I mean, is it major depression versus dysthymia versus bipolar, or with or without psychotic symptoms, or a single episode, or recurrent, or typical or atypical? The only importance I think that any of those terms have is that the diagnosis is a guide to treatment for the professional.
Is there a cure?
Well, we don't really speak in terms of cures because there's really no way to predict a recurrent depression in the future. Depression does tend to be a cyclical disorder, and one episode does put an individual at risk for future episodes. However, it is a highly treatable disorder, and treatment will almost always involve a number of methods combined, and it will be designed to target all the factors that are contributing to the depression. So the first thing is almost always there's a role for some kind of psychopharmacology or medication. Usually that will include an antidepressant, but it may include other categories as well. Sometimes mood stabilizers are used. Sometimes other medications are added to boost the effect of the antidepressants. Unfortunately, treating depression and most mental illnesses is not like treating a lot of other health conditions. It's not a matter of you've got high blood pressure, well, we'll give you and 10 other people the same medicine and everyone's blood pressure will go down. It really is a very individual and kind of idiosyncratic response, and so it is a method of trial and error, of finding the right medicine in combination with other medicines in order really with the threefold goal to treat the symptoms with the least amount of side effects in whatever combination works. The next thing will be psychotherapy, and that will be talking therapy to learn new ways of thinking, behaving, and coping. And this can occur in different formats. There's individual therapy, couples, families, group therapy. Also important is to treat co-occurring disorders. So if there is a medical condition that's contributing, then that needs to be treated. If there are issues of addiction, then those need to be addressed. And then finally, the final treatment that really is not used unless nothing else has worked is they still do use electroconvulsive therapy or shock therapy for depression.
And what are the consequences of untreated depression?
Sadly, it's very difficult to measure the human cost or the misery that is endured when depression goes untreated. Obviously, the individual who is suffering with the disorder, their functioning will be impaired in every area of their life, so that relationships suffer, their employment will be affected, substance abuse and addiction may result. Generally, major depression is time limited, meaning that it will partially resolve on its own. That may take months. For some individuals, that may take years. But without active treatment, it's unlikely that the individual will be able to return to their normal baseline level of functioning, and so that every subsequent episode will leave them more disabled and more at risk. In terms of the big picture, the economic costs to our nation are really, it's alarming. As the leading cost of medical disability, the cost of depression in terms of lost productivity and medical expenses amounts to $83 billion a year, which is kind of like an ongoing war. The good news is that it's a winnable war. Finally, and obviously the most tragic consequence of depression is suicide, which is a major yet preventable public health crisis, actually.
Is it possible to predict who will commit suicide?
Suicidal behavior is a very complex phenomena, and the risk factors vary considerably across genders, across races, across age groups. No one can accurately predict a suicide, but there are clear warning signs that signify risk. So my advice to you, as someone who obviously cares about this subject, Maddie, is never, ever ignore, overlook, or disregard a statement of suicidal intent. And if that is something that you are suspecting, do not be afraid to ask very direct questions about suicidal thoughts. And when I say direct, I mean things like, Are you thinking that you want to go to sleep and not